Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. This is a classic clinical presentation video. Today we are going to meet Brenda Bleeker. Brenda Bleeker is a 38-year-old female who had a baby 6 weeks ago, and ever since she has been having headaches. She has a past medical history of migraines as well as preeclampsia. Brenda has been suffering from migraines for a few years now. Since her delivery, the headaches have been similar in character, but recently they are significantly more severe. They have been coming more frequently and lasting much longer. She has had this one for 3 days, and it is really pounding. She is feeling very nauseated and runs to the bathroom. Headaches that over time steadily increase in severity, duration, and frequency suggest that something is expanding or growing in the head or brain. Listen closely for this pattern when you are taking a history. Back to Brenda, who has just run to the bathroom to vomit. While she was vomiting, she felt like something exploded in her head. And then the lights went out. Her husband heard her fall and came in to help her. He sat her up, but she seemed very groggy, and she was not making sense when she was speaking. So he ran to get his phone and call 911. The ambulance brought her to the emergency department. Her husband had told them that she had been having severe headaches since the baby was born, and that she vomited and briefly passed out. He relayed that she is usually in good health. She takes medication for high blood pressure, and it is usually under good control. When she arrived in the hospital, she wasn't able to give a history at triage. She was brought back to her room, and knowing that she had passed out, they did an EKG. The doctor came in immediately carrying the EKG. He was very concerned about the EKG changes. Brenda was not able to give him any history. She was awake, but not completely alert, and her words were unintelligible. This is her EKG. The EKG is consistent with a left main coronary artery occlusion, which is often deadly. We call it the widowmaker. But like every single piece of data, there is a differential diagnosis, and a left main coronary artery STEMI is not the only possibility. The nurse comes in and says, "Hey doc, I saw that EKG and I brought the aspirin and clopidogrel. Shall I give it?" The doctor says, "Hold off just a second." He did a full examination and derived this problem list, including left main coronary artery STEMI, headache, syncope, altered mental status. She had a Glasgow Coma Scale of 12 and no neurologic deficits. She also had severe hypertension. He has learned there is a short list of rapidly reversible causes of altered mental status. So he decides to address that first because if this was hypoglycemia, it would be crucial to fix it right away since the brain needs a continuous supply of glucose to function properly. If untreated, hypoglycemia can cause long-lasting effects. Here is a slide to illustrate the approach to acute altered mental status. It starts with the evaluation of the rapidly reversible causes. We think about that as don't forget the don'ts. Next, you do a neurologic exam. If there are focal abnormalities, the problem is likely to be structural, so an expedited CT scan is essential. If the exam is non-focal, then perhaps there is a toxin affecting the whole brain. This could include a drug, could happen after a seizure, or as in our patient, there might be an alternative cause. So a CT is a critical piece of the workup, but this one might need a little more thought before you rush the patient off to CT. the approach to acute altered mental status. I tell people to remember it as don't forget the don'ts. These are the reversible causes. It starts with the D. D in this case is for dextrose, because severe hypoglycemia can cause permanent brain damage. You can reverse that quickly with dextrose 50% given in the IV. Oxygen. Hypoxia can also cause brain damage, among other things, if left untreated, and it could account for altered mental status. So, checking the saturation or applying oxygen would be appropriate in these cases. Naloxone is the N. Opiate overdose can lead to respiratory arrest. Altered mental status is a warning sign that that may be the next thing that's going to happen. Naloxone is a medication that reverses the symptoms of opiate overdose. Thiamine. While thiamine deficiency can cause altered mental status, and it really should be treated immediately, it typically requires a lot of thiamine to reverse that altered mental status. So it's not going to fix anything quickly. And the S is shock. Check the vital signs. Check perfusion. You'll get some sense if you believe that your patient is actually in shock. This is the Glasgow Coma Scale. There are 3 categories, and you have to score at least 1 point in every category. Therefore, the score is never going to be lower than 3. First, we have eye opening. Our patient's eyes are open and looking at the doctor, so we would give her a 4 for spontaneous in that category. Verbal response. There are 5 possible scores for this category. Our patient will get a 3 because she's saying inappropriate words. Movement. This is a scoring scale of 6. She is not doing anything in response to command, but she does have purposeful responses to pain. Therefore, she will have a 5. Overall, the score will be 12. And just as a reference, and you don't always use this, but just to give you some idea of what the Glasgow Coma Scale translates to, people will say Glasgow GCS of less than 8, intubate. That's because people who have that significant of a decrease in their mental status will likely not be able to protect their airway. This is most often applied in trauma. The results of this evaluation show an AccuCheck of 120, an oxygen saturation of 94%, which is adequate. Naloxone was given, and she had a slight improvement in her mental status. But she never really had pinpoint pupils, so I'm not sure that that exactly makes sense. Thiamine. The symptoms are usually not acute, like our patient. So thiamine seems a very unlikely problem for this patient. And her vital signs are not consistent with shock. She seems to be getting a bit more groggy now. Now, I said that she had a partial reversal of her altered mental status with naloxone. It lightened up a little bit. Typically, in the case of an opiate overdose, naloxone works very quickly, returning the patient to alert and oriented. There are situations that cause endogenous release of opiates, which may cause the mental status to improve slightly with naloxone. There are also powerful opiates that may not completely reverse with a single dose, but they will typically have the typical syndrome with pinpoint pupils, piloerection, and a markedly reduced respiratory drive. The doctor is still thinking. A lot's going on here. But he wants everything to make sense. He knows that that is usually, in retrospect, what happens. So he's just going to take a moment to process. He's going to move that STEMI, which doesn't make much sense, down to the bottom of his list and concentrate a little bit more on the other symptomatology, the rest of the symptomatology. The STEMI does not match the rest of the symptoms, so he decides that we should not anticoagulate her or send her to the cath lab just yet. Again, her breathing, overall appearance, and vital signs are not consistent with a left main STEMI. The doctor says, "Let me ultrasound her heart real quick. Meanwhile, tell CT we need an emergent head CT and she needs to go right now." His cardiac ultrasound does not show any focal wall motion abnormalities, so she is sent to CT. As she's going, she vomits just prior to transport, and it occurs to the doctor that he should check her gag reflex, especially since she seems a bit more somnolent. He knows people with altered mental status are at risk of aspiration, and he would need to take her airway if she cannot protect it herself. Often, when people are markedly altered, the epiglottis can become dysfunctional and allow emesis to go into the airway. Just then, the radiologist calls and tells him Brenda Bleeker has a subarachnoid bleed, which has extended into the ventricles. The doctor gets this information and immediately calls the neurosurgeon. It appears that the patient had a rupture of an anterior communicating artery aneurysm, so this will need to be repaired. The anterior communicating arteries are the most anterior part of the circle of Willis. It is a common location for aneurysms, accounting for about 25 to 40%. And it is the most common type of aneurysm to rupture, especially in younger females. An aneurysm could be treated by intravascularly placing a coil in the aneurysm. That will then clot the aneurysm off and reduce the likelihood of rupture. Once ruptured, an operation may be done to place a surgical clip that stops the bleeding. The decision whether to surgically clip or intravascularly coil the ruptured aneurysm is based on size, shape, and current complications. This is decided in consultation with the neurosurgeon and radiology. Why was that EKG so abnormal? The pathophysiology of abnormal EKGs in subarachnoid hemorrhage involves autonomic nervous system dysregulation and high levels of stress hormones, primarily catecholamines. The morphologic EKG changes most commonly encountered in the subject with subarachnoid hemorrhages are U waves, T wave abnormalities, R wave abnormalities, and nonspecific ST T wave changes. The predominant rhythm abnormalities seem to be relatively benign, typically either sinus tachycardia or bradycardias. However, the possibility of development of supraventricular arrhythmias, sinoatrial blocks and arrests, and life-threatening ventricular arrhythmias warrants a close monitoring of the EKG in these patients. Risk factors for intracranial aneurysms are as follows. First, there's the modifiable risk factors, like high blood pressure, which is the most significant risk factor, and our patient is obviously very hypertensive at this time. Smoking damages blood vessel walls, which can lead to aneurysms, as can heavy alcohol consumption, which also often leads to hypertension. Drug use, such as cocaine, amphetamines, and other stimulants, can raise blood pressure and cause aneurysms. Head trauma. Previous head injuries can actually weaken blood vessel walls and then lead to aneurysms. Here are some of the non modifiable risk factors. Having a close family member with a brain aneurysm increases the risk for you. Aneurysms are more common in people over 50 years old. Women are slightly more likely to develop brain aneurysms than men, and certain medical conditions like Ehlers-Danlos syndrome, AV malformations, and polycystic kidneys can predispose to aneurysms. The common symptoms include sudden severe headache. That's the most common symptom, and people often refer to it as a thunderclap headache. Nausea and vomiting may accompany the headache. Loss of consciousness can occur when the aneurysm ruptures. A stiff neck, A potential symptom, along with increased sensitivity to light. This is caused by the meningeal irritation from the blood in the CSF. Seizures can be a symptom of a ruptured aneurysm, and double vision can be a symptom of both an unruptured and a ruptured aneurysm. What about that vomiting? Well, the area postrema, or vomit center, is located near the fourth ventricle, seen in red in the diagram. When blood accesses the CSF, gravity will likely result in irritation of the area postrema, which commonly results in vomiting. Forceful vomiting increases cerebral intravascular pressure, which may worsen intracranial bleeding. Okay, now let's get back to the healthcare professionals. After the patient goes to the OR, the doctor and the nurse have a moment to discuss what happened. The nurse says she is so happy that they did not give the aspirin and clopidogrel. She is glad that he took a moment to pause and reconsider the bigger picture. The doctor said he was just about to call the cath lab and give the meds. He is also so relieved that he did not do that. He feels like he had an angel working with him. Things move so fast, and he knows how easily he could have made that impulsive decision. They both vow to remain diligent and take the time to always be careful with their patients, even when the system encourages you to act quickly and follow guidelines without thought. Now let's check in with Brenda 3 months later. Brenda is out with her daughter in the park. The quick thinking of the first doctor played a big role in her good outcome. Thank you so much for learning with me. If you are interested in full course materials, please visit www.medicaleducationinminutes.com. Otherwise, I'll see you next time.